The following audio-supported podcast is intended for informational and educational purposes only and is not intended as medical advice. Please speak with your healthcare professional before making any treatment decisions. The guests on today's show were paid to participate in this podcast.
Welcome back to Just Listen, Voices of PK Deficiency. I'm your host, Dr. Rachel Grace. I'm excited to be joined today by two remarkable individuals and patient advocates, Tamara Shriver and Alejandra Watson. Each of these individuals has helped to bring together and provide support and education to the community affected by pyruvate kinase deficiency. As part of their work, each of them was an important contributor to the patient perspective on the newly available international guidelines for diagnosis and management of pyruvate kinase deficiency. On today's podcast, we will be reviewing these available international guidelines and their importance to the patient community. Welcome, Tamara and Alejandra, to today's podcast.
Thank you.
Thank you.
I thought we could start by talking a little bit about why guidelines are developed.
I'll go ahead and jump in and I can just tell you the story briefly of when I was growing up. I was diagnosed in 1975, and so at that time there were no guidelines. And I was in a remote area. I thankfully had a hematologist that was seeing me, but there was one pediatric hematologist in our entire city and two in our entire state. So between the two of them, that's how my parents were able to get care figured out for me. And it was tough because they used other patients that had hemolytic anemias to try to figure out, because there were no guidelines for PKD, to figure out how to care for me. And it was really sort of crisis management, meaning that I only was given transfusions if I was deathly ill. There was really no preventative treatment other than, like I said, if I had gallstones, then I had my gallbladder removed. And the whole piece about splenectomy, increasing my hemoglobin, wasn't even really known until I was late into high school and early college. So those were really the only pieces of advice that were available to me at that time. And so managing anemia, we basically did it by just not participating in school activities or managing my sleep. And so that was pretty difficult. And there also wasn't anything to manage jaundice or any of those things. So that would have been nice to have guidelines at that time. There wasn't anything. So that's, I think, just to help families have some universal guidelines to help manage the symptoms and everything that comes with PKD would have been nice.
I also would like to, on top of what Tamara just said, which is the most difficult part. She is a patient, of course. As a caregiver also, it's a different set of problems too. It's how to get the right education as a parent to how to manage these hemolytic anemias. But also, we are lucky. As Tamara says, she was thinking that it's only one hematologist in the area where that she was living. And when we're thinking broader, like guidelines, international guidelines, we are talking about countries where probably they don't even have that opportunity that we have in here. So the creation of the guidelines, it creates a totally different platform and network where the doctors can review the guidelines, whether if they have or not a hematologist that they can support what they are saying, but the guidelines can guide them. That's why they call guidelines, right? Guide them in how to treat a patient like that, or just to give it an idea of what is going to happen, because our guidelines, of course, included the management, the treatment, and the diagnosis, which is also the most important part.
I think those are such important points, and it's almost obvious how important guidelines would be from the patient perspective and caregiver perspective, nationally here in the US, but globally too. And I think as a provider, we love guidelines, that if you're someone who sees patients who have every type of diagnosis, it's hard to be an expert in everything. And in a lot of centers, specific hematologists are experts in a certain area. And so rather than potentially needing to review literature about a diagnosis that's very extensive and trying to understand what the best practice is, to have evidence-based guidelines that are already created in a single document with recommendations and the explanation for those recommendations. It's incredibly important for providers. It facilitates good care, that you're taking what's known and what's recommended directly to the patient without having to be an expert in a whole body of literature yourself.
I think it shortcuts it. It makes it a lot easier for sure.
Agios is a biopharmaceutical company that's fueled by connections with patient communities, professionals, partners, and each other. Building on these connections and the company's unmatched leadership in the field of cellular metabolism, Agios is pioneering therapies of genetically defined diseases, a broad group of rare and more common diseases that are typically severe and life-threatening. Near term, Agios is focusing on advancing a clinical pipeline of medicines for hereditary hemolytic anemias. To learn more about PK deficiency, visit knowpkdeficiency.com. That's knowpkdeficiency.com.
Can you describe how the PKD guidelines were developed?
From the patient perspective, we were very honored to be invited by a group of physicians and experts that were coming together to develop these guidelines. I will say also from the nonprofit perspective, we like to think that we were pushing for these guidelines, but I think truthfully, everybody in the PKD community, whether you were a patient or a caregiver, nonprofit, or a physician, I think we all came to realize that this was really important and that research was underway, that there were new treatment options available, and there was just more science available. So it was like the right time. It was the right time to write these international guidelines. And so when the guidelines committee came together, fortunately, they included the patient and caregiver perspective. And so as a patient, I was really excited to be invited to be a participant to offer the patient perspective, which I feel like was a valuable add because in the group that I worked with, the physicians were really high level and they were looking at the major impacts of PKD. And then from the patient perspective, I like to think that I added the perspective of, remember, this is what I'm experiencing. How can we make sure to cover this in the guidelines? And so I feel like that was the value of adding the patient perspective, was adding more of that in-depth perspective.
It was an honor to me to participate as a caregiver and give my input and prove how important it is to manage all together as a team for the benefit of the patient. And it's beneficial for everyone at the same time, the patients, the caregivers, the medical community. And it's not just the medical community as a hematologist, but at so many different fields in the medical community where it's helping to develop these guidelines. That was I think, for us as people, just without even thinking in nonprofits, but as a human beings, it was a huge goal accomplished. And it's just the beginning of so many opening doors. These guidelines open doors for so many other new things that we can find and we can help so many other people. Of course, it needs so much research. And still, we know that there's probably way more people out there, but they've been probably misdiagnosed, or it's not even a way to diagnose these people. So this groundbreaking, it was so important in every single aspect.
Yes, and I think what Alejandra points out, that it wasn't just hematologists, but it was nurses and it was people involved in genetics and people involved in how to study studies. And there were a lot of people that came from different lab technologists that came from every angle to really make sure that our librarians, that we were, first of all, researching the right research, evaluating that research, and that we were building the guidelines on evidence from conducted research. So we weren't building guidelines based on things that hadn't been studied, which is a little bit frustrating because there's some areas that we do have practices in that have not been studied. And so some of that is based on best practices we've extracted from thalassemia or we've just deduced. So some of those were gray areas, and we identified those gray areas in the paper, whether or not they actually had research conducted on patients with PKD or whether we had gotten that research from other areas. So we did a good job of identifying where the guidelines came from. And then some of the practices that we have in PKD actually have no research behind them. And we sort of addressed that too, as much as we possibly could, or they didn't have a guideline behind them.
I think what you're mentioning is an interesting part of guideline development that probably isn't recognized by a lot of people, that by putting together guidelines really comprehensively, looking through the literature and what evidence there is to support recommendations, you identify a lot of areas where we don't have research and we don't know the right answer. So part of guideline development is really pinpointing areas that need further research. And so to me, that's an exciting part of the guideline development too, are all the areas that have been clearly identified by this process, where we hope in another iteration of the guidelines will have answers to some of those questions, studies that have been conducted in the meantime, so that new recommendations or modified recommendations from the prior recommendations can be made, that we now have answers to some of those questions that we didn't know about. It's sort of a living document or a living process that the hope always is to make new versions as more information is known over time and hopefully new treatments evolve over time, that we have evidence to make recommendations around. I think also an interesting part of the guideline development that people might wonder about is, how do you decide what to make recommendations about? And how do you create those questions to see if you can come up with a recommendation? And from my perspective, one of the areas where the patient and caregiver perspective is so important is figuring out what are the outcomes of those questions that are key in determining how to make a recommendation, and how would people prioritize outcomes. For example, thinking about transfusions, what are the types of symptoms or findings that are impacted by transfusions, and how would you prioritize those? How did you all think about those questions and the outcomes in the groups within the guidelines that you participated in?
I think we looked at it in a very novel way. We are all very familiar with other guidelines and probably our own experiences where transfusions are designated at certain hemoglobin levels. But we discussed in our groups and within the larger group the fact that we have this PKLR gene. And from what we understand at this point, people at different hemoglobins have different symptoms. So it really doesn't make sense to have a hemoglobin as an indicator for when you should get a transfusion. And really, it makes more sense for your symptoms to be the indicator for when you should get a transfusion. And so we had some really rich discussion about that. And I was very pleased that we had the support of the physicians and all the people in the group to really support the caregivers and the patient's perspective, which is that when we feel really horrible, we need transfusions regardless of the number. And so when that was voted on, that particular guideline, there was overwhelming support for transfusions to be based on symptoms and iron overload. Obviously, you have to balance the iron overload part of it, but that those be the main two criteria as opposed to a set hemoglobin level. So that was I think, a big win for us as patients with PKD.
From my part of the community, the other risk factors that we were looking into PKD, one of them was pregnancy during PKD. Unfortunately, it's not so much research. So that is a great area where we are going to be looking into it now. But we came out with information that it can help other doctors, because As of right now, a lot of times pregnancies haven't been conducted as high-risk pregnancies. They think that the woman is going to be okay, and they don't look into the background of what else those needs. So to have just in the guidelines to prove it that a woman with PKD in being pregnant should be treated as a high-risk pregnancy, that is a huge accomplishment, because we need to look further into this research for women, and not just for pregnancy, but in general. It's so many other areas that we haven't been able to look into it, because a lot of things have been kind of a taboo, like a lot of things that we don't talk because it's uncomfortable for us as a human beings. When we are talking about our sexuality, it's very uncomfortable to talk about those aspects with a doctor. So we don't have all that information, but now we know that it's a more integral part to see a patient as a human being and not just as a patient with a hemolytic anemia. And we only have to look at the hemoglobin. I think to be part of all of us working together and trying to identify what is missing, what can we accomplish right now, it was so important. And like Tamara says, a lot of times, a lot of doctors, they don't want to look into how the patient feels. Even if his hemoglobin is 10, maybe it doesn't feel like somebody that is in 7 and it can do everything. So we need to look more into the patients or the community as PKDers and how their body's feeling, not just as number, because we are not another number.
I just feel so strongly that with having the caregiver and the patient voice involved in guideline development, I know that there were some doctors that were pro-patient and pro-caregiver, but if you can also have actual patients and caregivers there, it really spreads that to everybody else in the working committee.
I can add the diagnosis, which it was very important because we were able to put together 1 + 1 = 2 for the doctors to know how to properly diagnose patients with PKD and doing it at an early age and not waiting until they are 3 or 4 years old. Based on all the symptoms that we can present it now with the guidelines, it will be a little bit easier for a doctor or a neonatal doctor to look, oh, okay, maybe this look like PKD or maybe it looks something different. And then now they can find in the guidelines how to properly diagnose this one. And that is perfectly written in the guidelines.
Along with a very rigorous schedule for getting your thyroid checked, getting your parathyroid checked, getting all your endocrine hormones checked and your iron overload. We have a pretty rigorous schedule set up now for all of that.
And not only that, but just to set it in the guidelines, what test needs to be done in order to do your job properly. For a lot of doctors that they don't know what PKD is and they don't know how to treat it, they think, okay, we're just giving blood transfusions. But a lot of patients, they never had an MRI or a DEXA scan or so many other tests that needs to be done at least yearly. And when can they start? That is also in the guidelines. That is so important to give them a time frame when they can start to do this testing.
You had mentioned, Alejandra, too, about individualization of care and how important that is for people who have pyruvate kinase deficiency. And I think in some ways, what's unique about these guidelines is that when the guidelines talk about recommendations around treatment, there is a lot of individualization and even discussion around shared decision-making, for example, in considerations around removing the spleen as management for the anemia. But then there's also parts of the guidelines that are not individualized purposefully around monitoring, because we want to make sure that everybody has proper monitoring, as you're both saying, the DEXA scans and iron monitoring, and that these start at the appropriate ages. So it's an interesting mix in this guideline between individualization of care, which really happens around treatment, but that the diagnosis and the monitoring is pretty regimented in terms of the recommendations and standardized to not miss a new complication or issue and to screen early for them so that there aren't problems resulting from that issue. What do you think the guidelines mean for the community with pyruvate kinase deficiency?
I think for the community, it was like a dream come true. It's something that everybody was expecting. Everybody wanted to make it happen. It was not something that we were able just to go and do it, but it took a lot of time. It took a lot of years to get to this point. So for the patients, it's groundbreaking because now we have for the adult community, the older community, where they didn't have nothing when they were born, to now go to it's like an open eyes for somebody that like to see the light for the first time in their lives. See that, oh my God, I never knew that I had to get done this. I can go now with my doctor and tell him because a lot of the patients, they didn't have the proper monitoring, the possible issues related to PKD. So now they can go with a paper to the doctor like, look, this is something that you had to get it done. So the doctor can see that it's not just a fiction book, you know. I'm sorry for saying that way, but a lot of doctors, they think that it's this is not real. It's not a real thing. You don't need this, but it is. Sometimes they feel the patients that they are ignored. The guidelines bring them voice to the patient, which is a so much needed thing in the patient community.
I would second what Alejandra said, and kind of the way I would explain it is there's the push where we push out the guidelines to the medical community, and then there's the pull, which is the patient taking the guidelines to their physician, their nurse, their hematologist, whoever their practitioner is. And it's like they're advocating. These sort of empower the patient or the caregiver to advocate for their needs. So that's the push. And so the one part that I feel like as nonprofits we can be really proud about is the building of the website www.PKD guidelines, which we did in collaboration with the doctors. And that is for it to be sort of this easy to read PKD guidelines website, which has all of the guidelines and then other information to go with it that makes it accessible no matter where you are in the world. But the information is like super easy and you can understand it like at a glance. You can print out any of the information about the guidelines, take it to your doctor and say, hey, this is what I hear. Like, this is what's going on. And can we talk about my plan and what's recommended? And so that's the push that we can have patients and caregivers doing in addition to what goes on at the physician level. So I feel like the community has the tools now that they need. And that's really exciting for us.
And I want to congratulate you both on that website, which is such an amazing tool for understanding the guidelines. The publication of the guidelines itself with the recommendations is not an easy document and not easy to understand, I would say. And so having kind of bite-sized pieces of it that are written in a language that's easier to understand makes the guidelines so much more accessible. And that's such a key part because, of course, if nobody understands the document, then the guidelines and the recommendations don't mean anything. And we want these to be accessible for everyone across the globe, clinicians and patients and caregivers, and we want these to be implemented. And so I would encourage everybody to check out the website, which is listed with the podcast, and see all this information. And as Tamara just said, bring it to your clinician. You mentioned this already. How do you think people should go about bringing the guidelines to their clinicians, especially if they think their management hasn't yet been according to the guidelines?
The guidelines, in the way that we put it in the website, it's divided in different categories, which is the 5 categories that we did when we started guidelines. Each patient will be easier to navigate the website into the 5 different areas that they wanted to talk to their doctor, so they can look exactly what they need to take to the doctor. And they even print it out, take it to the doctor and talk about it. Or they can inform the doctor that is a website where he can find all the information that he needed, and you can even contact us in that way, we can provide more information for the doctor to get more education about PKD. Like Tamara said, the website is very straightforward, very oriented for customer, not just for clinicians, which can make it a lot much easier to read, to understand. And Dr. Rachel, you are totally right. It's very difficult to read it as a parent that it will be for a hematologist. So this website in these guidelines, it creates a lot much easier and understandable language for everyone worldwide, not just United States.
Yeah, I think it also depends on the relationship that you've had with your doctor or physician, but I think it is just understand physicians are people, right? It might be one discussion and they might say, oh, this is great. Yeah, we can make all these changes. Or it might be a physician that's like hesitant, or they've got a lot that they have to think about and it's going to take some time. I would suggest giving them a little bit of time. Just understand it's a change for the physician too. I mean, obviously Dr. Grace should give this advice and not me, but I'm just basing it on my past experience. I was working with a physician when I was trying to change some of how he was working with me. And so he did make some changes. We eventually got to the point where he wasn't making enough changes. It was like 6 months to a year. And then I decided that I would go to a PKD expert. And that was a whole different level of involvement where I had to find a PKD expert. So if you're interested in finding a PKD expert, you can look at the authors of the paper. They are obviously PKD experts. Or you can refer to Alejandra or myself, and we can help you find a PKD expert, or PKD friendly is another word that we like to use, that maybe that person's not an expert, but they're really willing to learn and they are learning the ropes of PKD. So, it's not like you can find an ally in one visit all the time. It might take a little bit of time. But the point of these guidelines and this whole project is to help people get better care. And sometimes that better care can take up to a year. And it takes a community of support. So this is like the first step to getting into that community of support, is this website and the conference and our support groups. And Alejandra and I can set you up. So that's the message that I would like to convey.
I wanted to add that sometimes even for doctors, it can be scary that somebody comes with all this information and try to tell you what to do, and you don't have the right answer. Like Tamara said earlier, they're humans too. Another of our suggestions is to give it a time and not pretend that you know everything sometimes, because we are working. At the end, we're working together. This is a teamwork. It's not just the doctor and it's just not the patient, but it's a teamwork. And we need to learn how to team up, right? Because sometimes especially patients with PKD and even the parents, the caregivers, we've been working for so long by ourselves, trying to be, or we've been isolated from the real world, that when you find all this, it's scary for us, it's scary for the doctors, it's scary for everyone when you move to a totally new you. So just always give a time to settle all the information, working out together, that it's for a better outcome. Because at the end, we will be facilitating a little bit the job to the doctor who doesn't know, and we will get a better care.
We were talking too about how the treatment recommendations are specific, but allow for individualization on purpose. And a big component of that is in shared decision-making, where the input from the patient and caregiver is shared with the input from the clinician. And it's really in that discussion coming up with a decision together in terms of a treatment strategy. And there can often be troubleshooting that happens along the way. You try something and see how the symptoms and complications are changing, and then you might make a change with some shared decision making and change the treatment approach. And so I appreciate both of your comments about that it can take time and that it's a team approach, because especially the treatment part of the guidelines is meant to be in decision making together. And it is incredibly helpful to have a strong input from the patient caregiver side in deciding what's going to make the most sense for that individual and what's potentially going to be most beneficial.
I think there is a traditional approach to medicine where the doctor tells the patient what's happening. And then there's this approach where it's the team approach. And that's what the patient wants. The patient wants the team approach. But unfortunately, that switch to the team approach isn't universal yet. There's still a lot of traditional approaches. And so I think some of us are still have maybe some negative experiences and from the traditional approach and some baggage from that. We're more than open to go to that shared approach. And so it does take some time to find the right doctor. And it's really hard when you're a rare disease patient and there aren't a lot of rare disease doctors to find the right rare disease doctor that has that shared approach. So that's, I think, what ideally probably patients and caregivers would like to find.
Before we finish up, I had wanted to ask if there was a particular recommendation or part of the guideline that you wanted to highlight for people listening.
Well, we talked about my favorite, which is the one that there is no set level to get transfusions. I think that's so important. In my experience, I have had to battle with physicians over needing a transfusion and not reaching that physician's particular set hemoglobin level. And now I don't have to do that. And now actually I have a physician who's more focused on my overall lifestyle, quality of life, and I'm in a much happier place. And it's taken some time for me to get there, and I'm hoping that other people can get that same relationship in their lives.
One component is the treatment, but another one is to give them a follow-up. Like, I've been always so advocating a lot for iron overload. As a caregiver, I experienced with my son a really dangerous levels of iron overload. And I don't blame it in the doctors, but unfortunately, we didn't have enough medications yet for iron overload, the chelations. In the iron overload, a lot of doctors think that is only due to blood transfusions, which is not the case with PKD. So that was one of the most important things for me that people need to understand. The iron overload in PKD is not just related to blood transfusion, but it's so many other different factors, and the absorption iron due to the rapid hemolysis that they are experiencing. And another big component for me is when they are planning for a family, it's a lot of taboos, it's a lot of unknown, yes, for women who have a PKD and they are trying to get pregnant or they are afraid to get pregnant, because it's so important to get this communication and try to open new doors with OBGYNs to better understand how can we manage this part. And it's a lot of things that they can learn from different experiences, different people. Some of them they adopted, some of them they decided not to have children. Some of them took more than what they were expecting to be pregnant. But all of this is a decision that only as women, it's so important for us to decide what we wanted to do and to talk to our doctors and get this wheel rolling. And the guidelines, it's such an important part for us to help us to get to the gray area to turn it into a nicer area where we have more information and more research.
One thing that we also put in the guidelines is just the recommendation for physicians to make recommendations to psychiatrists or psychologists or social workers, because I do think that this is not unusual, but rare disease patients have a lot of mental health issues that are secondary to having a rare disease. And to expect the physician to be the person to manage those psychosocial issues, I think is unfair for the physician to handle it. And probably they don't have the skills or the time. And so I think having that referral to the expert mental health person is a really good idea. There are a lot of people that really need some help, and it's okay. It's okay to need help, and it's okay to get a referral to someone to help you work through some of those issues that come with having a rare disease. And that can be for the whole family. It's not just the patient, but the entire family. So I think that's a really another big important component of the guidelines.
I would like to second what Tamara said. The psychosocial aspect is being so neglected for so many years that now is the time that we are standing up and open our microphones and megaphones to say we need help and we need to take it. We need to take it. It's not 20 years ago, not even 10 years ago, where if you were struggling with mental health, it was a terrible thing. You were always labeled. Now it's okay to be labeled. It's okay to say, yes, I have a mental issue and I need support. I need help. And that is the only way that we as a human, we can thrive in our lives. When we recognize what are our weaknesses and our strengths to do better in our lives.
And we love you, Rachel Grace.
Tamara and Alejandra, I want to thank you so much for all your major contributions to the guidelines, for your enormous efforts in making them available to the general community and easy to interpret and bring to people's clinicians, and for all your wonderful work in bringing together the patient community. It really is so remarkable to me how much you both do and how much you have accomplished over the last few years. And so thank you so much for everything that you do. And thank you for participating in today's podcast.
Thank you.
Thanks for listening to Just Listen, Voices of Pyruvate Kinase Deficiency. Don't forget to hit that follow button in your favorite podcast app so you don't miss an episode. Share the show with members of the PK deficiency community. And if you'd like to learn more about PK deficiency and see what resources there are to support people impacted by PK deficiency, visit knowpkdeficiency.com. That is knowpkdeficiency.com. Thanks for listening. I'm Dr. Rachel Grace, and we look forward to talking with you again.